Hi, Sarah. So maybe we'll go around the house and do quick round of intros. So we'll do it Health Excel style, rapid fire, your name, your title, and a fun fact about you. I might start with you, Robert.
Hi, everyone. Good to be with you today. My name is Robert Garber, and I am a partner at 7wire Ventures based in Chicago, where I focus exclusively on early stage digital health investing with a particular focus on how do we put tools, technology, and information in the hands of us so that we can be consumers and not patients. And a fun fact is I sent Chandana yesterday is I flew through London a couple of weeks ago and looked out on the runway and I saw a Concorde, even though the Concorde hasn't flown in probably 20 years, just sitting there at Heathrow. So it was cool.
That was the coolest thing. Yeah. Awesome. Welcome, Robert. Sarah.
Hi, everyone. Sarah Fisher. I'm heading up strategic finance for public health, global public health for Johnson & Johnson. Based in Amsterdam. And fun fact, I use the same one every time because I can't stand fun facts, but is that Bruce Springsteen used to be my neighbor when I was growing up.
That is a really fun fact. Welcome. Ken.
Hey, everyone. Yeah, thank you for the opportunity. It's nice to be here. My name is Ken Cahill. I am the CEO and co-founder of SilverCloud Health. Now part of the Aggarwal family. Fun fact for me, I suppose the most obvious fact if we weren't virtual would be the fact that I'm 6'9". So that's my fun fact.
Awesome, Ken. Joe.
Hi, I'm Joe Aggarwal. I'm the founder and CEO of Wysa, which is an AI-based mental health digital solution. And well, the fun fact about me is I'm one of the I think, courageous breed of founders that actually co-founded with her spouse.
That is really courageous of you. Hope that's going well for you. Looks like it is.
That's been fun.
And finally, Stephen.
Hey, good afternoon. My name is Stephen Smith, and I'm the co-founder and CEO of NOCD. And we provide online therapy for the obsessive compulsive disorder community. And one of the most prevalent and also misunderstood behavioral health populations. A fun fact about me is I played the piano since I was 3 years old. So, but still not really still that great at it.
Welcome, Stephen. And finally, I'm Chandana. I'm the general manager at Health Excel. And a fun fact about me is that people around me think I have OCD, but maybe I should use NOCD to figure out if I really do or not. Just because of all my neatness and cleanliness stuff. But anyway, welcome, thank you. So I'm gonna kick off by asking you, Ken, right? First of all, congratulations on joining the Aggarwal family. I think this is such a great testament to all the work you've done over the decades, I think, at this stage. And, you know, we'd love to hear about your journey, right? But in like rapid speed. How did you build this commercial model? You've tried different things, you've had to pivot, and now you're here with Aggarwal. So tell us a bit about that.
Yeah, happy to. I think the big challenge for me is going to be strategy is what happened in the past. So I can opine about how all the different moves we made were fantastic, and that's why we're here. Versus the reality is you throw so much at the wall, something eventually sticks. That's the hope. And that's kind of the entrepreneur's lament. Yeah, so we spun out from research in 2012. So we spun out from nearly a decade worth of research, which was looking into, it was later stage academic and clinical research, looking into how do you digitally deliver access to behavioral health or mental health care with the big barriers of low patient engagement, high patient dropout, and limited clinical improvement. Essentially, those digital solutions didn't actually work when they went live into the real world. And there was a couple of various sort of vendors in the market space at that time, particularly in the UK. The hotbeds were the UK, Australia, New Zealand, and the Netherlands as well, which was interesting in terms of adoption at that point. So spun out in 2012 to form who we are. You know, we both, in our first year, we brought our first NHS customer on board, and we also brought on Optum in the US, which was quite an achievement for a small Irish company with about 7 people. We probably doubled down on the UK market first because we saw the I think, you know, we're talking about commercialization here. It's the flow of financial and healthcare dollars. You do need to follow it. It's unfortunately the reality if you're a commercial enterprise in order to get paid. So we went after the NHS market, which today we would have about 84% of all NHS and mental health services using our platform to deliver care across primary and secondary care. And the commercial model has been quite straightforward. It's just been essentially be it either a licensing or a population coverage or utilization model has really been what we've focused on. So we believe the utilization model more closely ties us to what our customers and partners want to achieve versus a sort of a flat price band over full population, you know, a per covered life type model maybe doesn't incentivize you as closely as the customer or partner would like it to be. So yeah, that's been the model. Happy to answer more on that.
Yeah, very interesting. So I guess the big message is follow the money, but would love to dig a little bit more into how you're pricing for outcomes.
Yeah, so we've evolved the pricing model, and I think a lot of digital health companies will the ones who are delivering results, the ones that work, are and do struggle with the results they're delivering digitally, and then they're maybe getting cast into a bucket of a SaaS product or a piece of software, and therefore the vendor may only want to pay X for it, yet you're delivering a replica, a better version of, although you have to use the word on par, an on par version of what would be more traditionally delivered in care. And sometimes that gap between what you can charge for software versus what you're replacing can be quite wide. And one of the ways that we've narrowed that gap is by doing it on a risk or a value-based pricing model. So putting a certain percentage of contract available based on us achieving certain performance metrics. So outcomes number 1, activation number 2, and user satisfaction number 3. So if anyone gets fired for picking a digital health solution, it will be because it never got used, it didn't work, and the people who it was given to it, they didn't like it. So that's why we came up with those 3. Okay,
very helpful. We'll come back to that in a second. Joe, you've kind of used a slightly different modality of delivering mental health care to patients or the general population, right? So your positioning is the digital front door. Can you say a bit about your model versus, say, SilverCloud, which is more so a therapeutic intervention?
Absolutely. When we started out as a direct-to-consumer app, and we were seeing lots of real-world evidence of people using it, but a year after we launched, we had the NHS, actually similar UK, I think, as a pioneer in this area. We had them contact us to say in their adolescent service, this seemed to be the only thing that was working in waitlist management. So they would give people a lot of different options, and they just didn't have enough therapists. Waitlists were long even before COVID. It's running through the roof right now. And they would, 30% of the people wouldn't need anything else if they were given Wysa. And that's where we started realizing that we needed to make it clinical. We needed to go. So we went through Orca, which is the health app rating agency, and we became the top rated app on Orca. We then used that sort of knowledge to put all the right assessments and safety standards and all of that in place. And increasingly, we began to see that public health, Ministry of Health in Singapore then benchmarked against every other product out there, and they needed something that everybody could just go to and self-serve. And Wysa, for those who don't know, is an AI conversational agent. So our main hypothesis was that whereas most digital therapeutics were using e-learning the way it had been, I come from an e-learning background, but e-learning as it had been designed, which was, video followed by certain questions and so on and so forth, what people were really looking for was a place to be heard. And by giving them a place that was both clinically safe and allowed them to talk in free text in what they wanted to talk about, and being able to both triage and support them with 90% of the people feeling better after their first session, and some of them then going into either a digital therapeutic mode or an e-triage into a therapist. That became something that gave our customers an ability to string together the myriad of resources they already had. So we became that thing that everybody who had, for instance, Accenture as a customer who already had a large number of resources, everything from Headspace and Calm to Optum, would bring us in to string it together, and people for the first time would have a place they could go in and talk. Ministry of Health in Singapore did the same. NHS now adopted us through their NIHR grant for adopting AI into mental health. We're finding that the digital front door is a good landing pad. We have our digital therapeutics with, as Ken talked about, great outcomes, but very often, getting clinicians, getting to the clinician who would prescribe or getting even to the assessment that would lead that to be taken up becomes a bottleneck. So we've gone in earlier to relieve the bottleneck in our customers, and then say from that point onwards, because there's great engagement and great outcomes there itself, those who get triaged into the digital therapeutic, they would pay on outcomes and usage, but on a small cost, a population could all have access to the digital front door.
Okay, very interesting. So your main KPI is reduction in the wait list or giving quicker access to those that need it. That's great. And
reducing the burden on the clinicians. So what you're getting is a happier customer, a user who gets instant support. You get the right people to go to the clinician, and a reduction in clinician time.
And is it a similar licensing model that Ken spoke about?
So we tend to have a utilization-based license on the digital therapeutic element, where people go in for programs which have given outcomes, and there is a risk-based pricing, again, against outcome and ROI that we can show. But the digital front door, where it's accessible to all, can be a very low cost per person, but is at a population level.
Got it. Super. And Stephen, then I know you have a community-driven model. Can you say a bit more about how that is your commercialization strategy?
Sure. Community-driven therapy is a term that our team has been vocalizing in the market, and the reason for it is, for the more severe populations, like people with OCD, for example, it's very difficult to identify with what someone has. They oftentimes have lots of comorbidities, but they usually have a central issue that they would define as what's quote unquote wrong, right? And they oftentimes communicate what's wrong in ways that are typically not standard in healthcare. For example, people may communicate online versus to their PCP because they're afraid that communicating what's really wrong to PCP will have consequences. I'll give you an example. So OCD is very misunderstood, right? It's actually similar to PTSD, where PTSD is intrusive thoughts about the past. So for example, you might have a war veteran who has flashbacks to their time in Iraq or Afghanistan. OCD is intrusive thoughts about the future. So, we oftentimes think about OCD as a personality quirk or an adjective used to describe somebody who's type A, but in actuality, it's a condition where people have these very taboo, what they call intrusive thoughts. They recur in someone's head, and to make them go away, they use very specific actions. Those actions are oftentimes private, or they could be public, where you could see what someone is doing. The reason why I'm bringing that up is because most people don't understand OCD, right? So people will communicate what's wrong. They'll say, I have intrusive thoughts of what if I accidentally hurt my child? And people will think of OCD equals, hand washing or contamination. They don't think about it as violent intrusive thoughts, or religious intrusive thoughts, or sexual intrusive thoughts, relationship-based intrusive thoughts. So what happens in our setting, in our community-driven setting, is people talk about those core themes online. We create content that's both user-generated and key opinion leader generated that meets people in that journey. And they actually learn that what they're going through has a name. From there, people then can go in and connect with very personalized treatment that we offer. And we as a treatment provider, virtual treatment provider, can actually understand what someone's going through by seeing how they engage in our community. And we can deliver that personalized intervention for them. For example, a mother with postpartum OCD, in fact, 7.8% of new mothers, she may fear, what if I accidentally hurt my children? She may not be comfortable enough disclosing that to her PCP, but she'll go and search online, intrusive thoughts about hurting my kids. Yeah. And so then what happens is she'll connect with one of our therapists. We'll understand not only that she has OCD. She has comorbid depression as a result, comorbid maybe severe anxiety, but she's also suffering from this very specific subtype. And so our therapist will understand that and will then treat her accordingly and then step her down to technology when she's at a lower acuity level. So the idea behind community-driven therapy is, one, you can more easily identify, quote unquote, what's wrong with people that are in the more severe populations. And two, you can more easily manage them in a personalized way, giving them the experience that members want, right? And so a core concept at NOCD, or core value, I should say, is the term members first, right? Everything that we do is to give our members an A+ experience. So that's the concept of community-driven therapy, and we function like a provider to specific payer populations, where people can come in, they can access one of our licensed clinicians that has deep specialty in helping them, and then they can get support between sessions from different self-help tools, peer communities, and then eventually they may not need their therapist as much. They can just use the technology to keep themselves healthy long-term, and we'll in fact connect them to other important resources.
Okay, and who's your target customer? Is it D2C?
So we work with payers. So
Okay,
we work with payers as a virtual provider, as a specialty network.
Okay. Sarah, Robert, so you both actually have a bird's eye view of the different commercial models, and if anything, over the last few years, and rightly so, we've seen a huge surge in digital mental health delivery products and companies. What do you think in terms of commercial models are working or not working? What types of models are having the greatest impact and giving return to the folks working on it? Okay, both of you being super polite. Maybe Robert.
I made a gesture that Rob can go first.
Yeah, I mean, I think the jury is still out. Yeah, I think there are a number of different ways to slice the market, and we just heard from 3 totally different engagement models that are trying to solve for engagement for consumer experience, and then also for the specific conditions involved. And I've said this before. I think we need to be careful about lumping all of behavioral health into one sort of list of categories, as it's a very heterogeneous set of conditions, right? And so, comparing somebody who has a pure substance disorder to somebody who's bipolar or has schizophrenia, these are very, very different conditions that are treated very differently. Some conditions obviously have significant medication components and others don't. It seems to me, from what we've seen, there are a few areas where we've seen some early, success, and certainly Ken and Joe and Stephen can talk about their respective areas. I mean, fortunately, a number of the offline tools and modalities that existed sort of pre-online world have been successfully migrated. And so, I sort of talk about this as like the digitization of existing solutions. So we're taking offline modalities and we're moving them online, and we're leveraging technology to improve scalability, democratize access, and hopefully reduce costs. So that's all a good thing. And those are simple things like CBT or coaching with mat therapy for substance abuse. I actually just saw a company that's doing some really interesting work on bipolar and schizophrenia, which at the SMI side of the continuum are obviously really severe conditions. There are a lot of good online solutions that are working for anxiety and depression. So I think we've seen a lot of early positive signs across a number of the conditions. And I don't know. I mean, I think we saw 3 different approaches here. There's no one magic answer here. I mean, I think, Ken, you're right. Like, the goal is get people to use it, get people to like it, get people to feel better, right? And then keep them better, right? We talk about, Stephen and I've talked about this, like there's a phase, it's like they get better and stay better. Like, first you try and get the people better, and then you stabilize them and hope they keep better and don't regress. So I think we've seen both sort of success in models and success in conditions, but I still feel like we're at the digitization level. Like, we haven't gotten transformative. We aren't fundamentally changing the intervention modalities yet. I think in 5 years, we'll look back and be like, wow, the technology opened a whole new level of things that we could do. And Joe, I know you're doing some of those and sort of trying to reduce the burden on clinicians, automate some of what can be automated. But I just think, we have new delivering tools that we didn't have before. And so, I'm bullish to see what we can think up in the next 5 years, and how creative we can get with sort of adapting treatment modalities to the online world.
Yeah, and I don't know what I can add to that is I just think most of the commercialization models and the variations that you hear, they still sort of hang or depend on the engagement model. So if you think, okay, I'm starting off with, I'm gonna, who is your customer? Well, my customer is a payer. Who's your customer? My customer is the NHS. And most likely, I mean, sure, there's a payment aspect to that, but there's also how do I access and engage these patients, right? That's really the question that they're trying to get after when you're providing a solution in the market. Like, how are you going to bring them out of the market and into using your solution? So there, I think many commercialization models we see right now have to do with engagement, plus the question around specificity versus generality, right? Which is something that Rob just brought up. So there are, I think, instances where you have general solutions like, open up or mindful, just call somebody, it's almost like a hotline, right? And start talking because we don't even know what's wrong with you yet. We can't figure out how to engage you, but we're just, what channel to send you down. So I think there are some general solutions that still are valid. But most often what I hear from investors and people looking at the mental health market is it's very difficult for somebody to really understand how to allocate capital into mental health, brain health. What's the difference between mental health and brain health? What areas are, if I'm putting my money into this vehicle for mental health, actually, what am I addressing? What aspects of mental health am I going to get after? So there really is that sort of lumping up of this term, which I agree with Rob, really needs to be broken down. And even if we start with more specificity around the differences between mental health and brain health as a starting point to use those terms more accurately, I think that would do a lot for actually attracting the right capital to the right kinds of companies, and helping also to understand the right commercial models for companies that are in a mental health space versus a brain health space and vice versa. And the last point I would bring in, which has been exacerbated by the COVID situation as well, is most of the time we're still talking about solutions for the developed world. And in my role in public health, clearly there is application. It may not be venture fund timeline application, to be clear, but it can be impact blended finance model type solutions that could address the mental health burden that is happening also in low middle income countries. And there, I think there's also, it's a huge amount of opportunity there for companies who are able to scale and to at least provide part of their focus to those parts of the world, or attempt to anyway. So those are solutions that that I look at a lot at the moment now when it comes to the mental health space, is this democratization outside of the developed world to also address the globe, really. What does that actually mean? And there, I think there's a lot more interest in that space than there was historically, thankfully.
Any reflections from Stephen, Ken, or Joe?
Sure, I'd be happy to add a reflection. So one of the areas for opportunity that we see just from being in the market is with identification, right? So when you think about management of different behavioral health populations, there's a low mid acuity group. You're seeing a lot of great innovation done with technologies, stepped care models, right? And then you have kind of the SMI cohort. And as the more severe you go, the more complex people often become, the deeper the treatment becomes, the more complex the care pathways become. And so you address that heterogeneity with personalization and depth. Whereas for some of the lower to mid acuity populations, you could have tech-enabled coaches or ancillary providers, or simply just technology and digital therapeutics that can help. What's interesting though is that most people know what's wrong. They may not define though publicly what's wrong, right? And so to capture the cohort of the market that is ultimately the most severe and in need of help right in that moment, you oftentimes have to relate with them and build trust with them, right? And so what we've seen is that sometimes it's hard for the current system today to identify really who has what, and also what is most wrong with that individual. And so, yeah, but I think people, they actually are able to define what's going on. And so if there's a way to somehow innovate at the top of the funnel and improve identification of different behavioral health populations, you'll ultimately solve this problem, because there are great solutions today downstream that can make a major impact. So you see, for example, as Robert described, there's solutions in the schizophrenia community or bipolar disorder community. There's also great platforms today, and you hear two great platforms that were just described on this call, right? So there's lots of opportunity, but it really starts with identification.
I'd 100% agree with that. And in fact, I'm walking away with great inspiration in how Stephen's using community-based therapy for identification. And we're trying AI to use AI to do exactly the same thing. Because the key to identification, I mean, in a direct-to-consumer experience, organically with no marketing, we have 4 million users from 65 countries. 99% of them are unpaid. So this is a community that actually comes in and just talks and cannot afford it, but many of them go on to seek therapy later, but many of them do not have access to it. And that takes us to, we need to increase access, to Sarah's point, by language. That becomes, by putting it in everybody's phone and making it free, we were able to increase access. But now we're talking to grant providers to, for instance, in India, do all the local languages. We've already got a Spanish version coming out. And we have 18,000 volunteers across 20 languages that just say, please get it in our language. So we know that there is need, and there are people who will seek this out on their own. So that activation bit that, we all talk about, that how do you get to the right person? Very often it's about creating an anonymous platform where people can just go in and talk, self-identify, and also either as a peer community or in an AI conversation, and then feel safe enough to take the next step and make it easy for them. And I think whether we make it easy for the developing world, which is a large part of our mission, if we want to reach the number of people that we want to, that we've planned to, but also in the developed world, we found that to activate the people who wouldn't access help, you need to build that brand that this is safe, this is easy, this is instantaneous and anonymous, and just let them talk and listen to them rather than give them a way to solve it right away.
I'm also going to ask a question of the group. So I think we've identified how to maybe address some of the supply demand challenges we have, just in terms of the modalities of engagement, right? But what commercial models actually lend themselves nicely to making sure we balance the demand with supply? Have you seen that already in terms of what products you've brought to market? And Robert, Sarah, have you seen that? Because I think that is going to be the challenge of the future.
Yeah, I mean, we always talk in our shop about sort of tech plus touch, right? And so how do we get the balance right? And ideally you, on the tech side, automate what you can, and on the touch side, create a hierarchical approach to clinical intervention, so that you have, coaches, and then next level clinicians, and then next level, so that you can create a risk stratified model to leverage the appropriately licensed people at the appropriate level. That said, it still feels like we've got a lot of work to do on the supply demand problem. I think we have a couple of sort of factors. One is by democratizing access, and perhaps in a digital world, destigmatizing some of the mental health conditions, we're increasing demand. And that would have happened independent of COVID. The COVID component has only made that worse. And so we have sort of surging demand, and we don't have the accompanying increase on the supply side. And I think there's both sort of a shortage of supply at all the different levels. And then there's also, to your point, Sarah, like the distribution of that supply is off, right? So it's, people in cities might have better access to resources than people in rural communities. People in first world countries have better access than third world countries. So like we have sort of, problems of both magnitudes. And it feels like we're early days here. If everybody woke up tomorrow and said, not only do I have a mental health issue, but I want treatment now, the system would be completely flooded. It's already flooded, and be even worse. So I haven't seen sort of long-term solutions to it. I see people chipping away at it, and I feel like we've got a lot of work to do there.
Yeah, I agree. And then the other thing, just again, is like from an investor lens or looking at the market side of it, I would say, generally in some thematic areas, at some point you could already start to see some consolidation. And I think there's been some deal activity that we've seen of, solutions coming together, but with such a broad bucket of solutions right now, or that specificity versus generality. Are we talking mental health? Are we talking brain health? And like even trying to think of how a private equity player would be trying to like puzzle piece this together to try to come up with like an all-encompassing solution. I'd say this field is still quite a difficult one to navigate in that respect.
Yeah. To add one point, the real question that I have is, where is the fixed market supply of therapists going to be over the next 5 years? Because today it's kind of spanning across the entire continuum of acuity level, right? You have low to mid acuity level populations that are seeing therapists, and then you also have higher acuity level populations that are seeing therapists. But where is the therapist supply going to end up? I think that's really going to come down to whichever populations or whichever solutions can drive the best outcomes for the most severe cohorts of the population. And the reason for it is that's where the cost savings impact is going to ultimately be. And that's where the therapist supply can make the biggest impact, in the market, right? And so what's going to happen is you're going to see rates start to increase for those services that can make the biggest impact, both from a clinical and economic outcome standpoint. And that's going to pull the supply up to the higher acuity levels. Which may leave opportunity for lower to mid acuity levels to seek treatment from ancillary providers, from different tech-enabled services that are 100% tech in some ways, that may be able to escalate people up. But I think you're naturally going to see the emergence of the therapist population going to the populations that ultimately need it the most. And it's an interesting time though, right? Because the question now is, how do you get people who need help the most to actually go to get treatment, right? And that's sometimes the biggest challenge, given you're going to have to change ultimately consumer behavior if you were to identify those folks in the healthcare system. But if you meet those people where they are in their own journey, right, you could potentially fit right into their own workflow, right? Which is they navigate the day-to-day, and you bring the healthcare system to them versus asking them to go to the healthcare system. So that's an
interesting chicken egg Stephen conversation though, because like if you think about conditions that are on the brain health side, like schizophrenia, the most difficult to treat patients there are not engaging in digital, right? You're not going to find them, like you're not going to be able to tap into them through some application and try to engage them that way. So if you're looking for like fast cost savings, to your point, then you have to find difficult to treat patients, which depending on the condition, digital is either a tool or it's not, frankly, right? So that's the challenge there. You have to segment these conditions with, depending on severities, does digital even remotely make sense, and not start to try to apply digital to all things, because that definitely won't work. And the other way to do it then would be the real cost savings then would be the earlier you could identify, early identification and earlier engagement on the prevention side, which of course is the longer term, more difficult economic story to prove out, but a very real one. And there you could say digital does have application, but of course that really puts a lot of burden on companies like yourselves and others who are trying to do the economic proof for that through your digital applications. Whereas obviously, trying to get a home run in severe patients where you can quickly measure, or more quickly measure the progress, is easy an economic story to do. So it is a little bit chicken egg there to try to say target only severe, because there's many conditions that severe is not even remotely interested.
Right. There are populations in the severe cohort, like OCD, for example, though, that are, when untreated, extremely severe. For example, people with OCD are 10 times more likely to die by suicide, sadly, when left untreated. They're also typically suffering from extreme depression and whatnot. But also there's effective services that can be delivered to people and get them better much faster, right? And I think there are other subpopulations in the SMI space that are like that. And so what's, based off the prevalence level, if you have, for example, 1 in 40 people suffering from a condition that's severe, but also yes, treatable, and you go deeply into that vertical, the therapist supply is going to come with, because you can serve enough people in the market, and you can also give that incredible experience to the patient ultimately, which is most important, right? Because I think that to your point though, the treatability level within the SMI cohort is going to be huge as we progress here over the next 5 years.
Ken, I feel like you have answers as well here.
Yeah, I think if we take it up a level, I know this is going to sound quite obvious, so hopefully I don't take your hope of what you're going to pitch this webinar for. I hope I don't take it back to what we're doing is good and we need it. But for me, I think I almost look at healthcare as being either a funnel or a filter. And the challenge is everything comes in it at the one time. And it is all fully humanized in terms of, barring the sort of latest tech, it's all humanized in terms of how those people get routed and routed and signposted and moved around the system that's there. So that creates a huge choke point. A single front door, a single desk, and then you're meant to navigate all the way through a hospital or health system or entire network. So the challenge is we have this whole wide spectrum. So we have SMI, we've comorbidities, we have interventional challenges, we've got the worried well, we've got there's a difference between somebody who has diabetic distress and somebody who has depression. Which came first, the diabetes or the depression? And those kind of challenges. So everything kind of comes in at one time and just blocks up and clogs up the entire system. The approach we've taken for the last number of years has been a reasonably simplistic, but it has to start at one stop or one step, which has been basically the approach of let's deliver one-to-one care virtually. A kind of Cisco Systems approach to the world, whereby all you're doing is connecting a therapist to a client. And I'm sorry, that's really important work when it's a theater of war or in rural or isolated populations, absolutely. But for mass adoption, mass delivery, for us to tackle the challenge we have today and the challenge that we will have post this winter, which is going to be even more than we have even today, we need to leverage the technology to help. So that means moving it from one-to-one to one-to-many. Being able to scale, being able to, yes, for those percentage of population who would do better and need face-to-face or pharmacotherapy or other, we give them that. And those who would do better in terms of digitally delivered or digitally assisted delivery, we give them that as well. I think that's a really important joined up thinking. We always say at SilverCloud, we're not the silver bullet. We never plan to be, we never want to be. We are part of the offering. We're part of the portfolio that is needed to deliver mental and behavioral health care.
Well said. Sarah?
I was going to shut down. You have some questions on the side.
Yeah, I will address them and welcome all other questions as well from the panel, from the audience. So there's one question here. What activities are you launching to ensure activation and to increase engagement? So I'd assume this is obviously addressed at Joe, Ken, and Stephen. And you go first because you said engagement is one of your three.
Listen, it's the biggest challenge that presents itself to us organizations, if you will, is that activation engagement piece. I think first starts with me is making sure you're not delivering one size fits all, generic offering. Here's a happiness program for someone with moderate to moderately severe depression, and likewise in reverse. Also, the right titration level, the right context, the right appropriateness. You're trying to meet the person where they are versus the yesteryear it was, here's a CD-ROM, go sit down in the clinician's office on a yellowing computer, if we all remember them, and go through this DVD or CD-ROM. Versus much more tailored, more precision digital mental health care. But activation engagement is a huge challenge for us all. not overwhelming someone when they begin and not underwhelming them when they're 3, 4, or 5 weeks into a program or a course or whatever it is. I think making sure your pathways are correct, it's set up in the right way in terms of the materials, the prescription pads, the integration with the electronic health record system, so you get prescribed a course by the clinician if that is the way. And then for us, I think after that, it's just data. It's just pure numbers in terms of making sure we see this kind of three. There's 3 stakeholders for us. There's the sort of patient, the member, the user. There is the prescriber of SilverCloud, and then there's the purchaser of SilverCloud. And they are 3 different types of people, and they've got 3 different views in the world, which are very, very different. In order to get the activation, you kind of got to get all 3 humming and singing in the same sort of way or method. And then in terms of once you kind of get them activated, engagement then has to be about delivering something that is of value, therapeutic and other, something that is competing with the rest of their life in terms of television, YouTube, Facebook, whatever it might be, and you are competing with them. And if you feel you're not competing with them, you're kind of missing the whole point. You have to deliver something that feels like there is a therapeutic value within 5 minutes and one that feels there's a therapeutic value within 2 hours. If you look at asking somebody to, and we see it on our platform, you will see 2 different age cohorts. If I go to the complete opposite spectrums, one age cohort will interact with the platform typically on a Friday morning, typically on a tablet device, typically for 1 hour, and typically with their partner, sort of the senior population. We'll then see the other population, which would be the far younger population, will interact with on 3 different devices 5 to 7 times per week. You need to get all those to stick together. If you hopped into Netflix and watched a box set back to back, does it make sense? Or you break that box set up into 15-minute chunks? It's a challenge. It's a challenge.
Very interesting. Joe, any answers?
I could, our activation is very different because it starts very general and then goes specific, but our engagement, I think we've done something quite innovative in terms of creating precision engagement. So because it's AI, you're able to, for instance, we found that people who, when they were doing a cognitive restructuring exercise and were upset with a partner for cheating on them or with a parent, so there was either power inequity or trust issues, the traditional CBT approach of this is an unhelpful thought and let's challenge it so you can feel better was not working. And we had 10,000 users write to object, and our AI would detect that objection and our analytics would flag that up. And then we created new AI models to detect those situations and then worked with clinicians to iterate and figured out that for those people, you need to give them a sense that they're getting back control in that situation. And that's what will get them to go through the cognitive restructuring exercise. And we wouldn't have known what are the cohorts that won't do self-help the way it's been designed unless we could listen to them. And unless there was an analytics layer, there's an AI layer categorizing their free text responses, an analytics layer then saying this is where it's not working, and clinicians then coming up with new hypotheses. And that allows us to do that precision engagement where we can actually en masse over 500 million conversations, really begin to say that, okay, in 10 minutes without any explicit psychoeducation about CBT, people are actually able to successfully complete a exercise and feel heard and validated all at the same time. And that just brings it into, I guess, engagement and activation has been a core part of a product design when you start out in direct to consumer. And you keep refining it until you bring it to the clinicians. So you're now proving your efficacy, which we've got fantastic results at. We started out with cohorts that were very young, and to Ken's point, they're very different because they're early adopters on technology. But then when we did a clinical study with 53-year-olds with 9 years or more of chronic pain, using the same thing, we said, let's throw in a coach because they will feel we are just talking to AI. And we found that 50% of them didn't talk to the coach at all. 80% of them completed it. We had results that were better than the gold standard of a therapist. But we had people, not using the coach at all. I think 80% of them didn't use the coach more than twice, and 50% not even once. So we do end up, once people come in and start using it, they see the value of the digital, but you do end up having to throw in a human element just to activate them sometimes.
Yeah. Okay. Very interesting. I have a great question here. Can you provide a view of the top 1 to 2 areas of one and one-to-many opportunities across the mental health value chain? It's a bit of a mouthful, but
sorry, is that to me or?
It's to everybody, whoever wants to take the question first. Go for it, Joe. Yeah.
For us in the digital therapeutics area, we want to focus on comorbidities where there is a physical health outcome like cancer survivorship or chronic pain. So mental health associated with these things, because in the short term, it's easiest to commercialize because we can, for instance, show a difference on the physical health outcomes. And that allows us to make a business case much easier than in some of these things. It's hard to prove the overall mental health outcome if it's not super severe.
Robert, Sarah, any thoughts on your top 1 to 2 areas of one-to-one to one-to-many opportunities across the mental health value chain? Maybe think about it. I think that question needs a bit of consideration. So while you do that, another interesting question here to Robert. What are your thoughts about creating digital-first therapies going beyond the digitization of proven analog therapies to improve engagement and recovery rates for specific conditions? And would such therapies run into compliance bottlenecks because of relatively lesser evidence?
I mean, look, we all hope that we get to a place where we have digital first. I think one of the things I always have to remind myself is Ken may have said this, like, we've got to follow the money. You have to figure out a way to get into the funds flow of the existing system, really to get commercial traction right now. And some of the digital first solutions that have been in the market, like it's a heavy lift. I mean, you've got a body of clinical data that's pretty significant, especially if you're advocating for a different therapeutic modality than one that's tried and true in the market. And so I think we'll get there, but we're never going to remove the touch component. We're just going to optimize it. But I think the reason, we've looked at a lot of solutions, right? And it makes all the sense to go digital first. It's scalable. It's, it's engaging. It's anonymized. It's, less stigmatizing, less intimidating. I mean, it's like the same idea behind, if you look at telehealth, the number of people who want to do voice and not video, like the anonymity of it, like it's not in your face. It's not so threatening. So it makes all the sense in the world. I just think that the clinical data is going to take a while to build, and it's early days. It's early days. I mean, I think, look, the digital approach, at least in the US, the digital only or digital first solutions seem to be like the Pears and the Achilles who've been going the FDA route with a really mostly digital solution. I'm glad that they've raised hundreds of millions of dollars to educate the market and pave the way, but it's early days, especially when you look at utilization on a basis. It's low.
I'd love Ken's perspective on this because, Ken, you've been so focused on evidence generation. You've also been through the NICE tiering system. What are your thoughts on that question?
I think it's one of those ones you absolutely have to follow the money. And I'm kind of saying it as if I didn't say it, but I did. I know I did. But you do have to follow the money because otherwise you won't be able to do and deliver the good that you're trying to do. And you'll just get caught out as a tangent of care, and you'll get no adoption, no subscription, no prescription, no delivery, no results. So you have to integrate within and either become part of the flow or slightly disrupt and become part of the flow at the same time. then you have to prove what you're doing works or is delivering the value. And it can't be just soft ROI. It kind of has to be that hard ROI. Claims data, healthcare utilization. And again, that challenge, that we all face, which is the bill point of software as a service, the SaaS price point, and they'll only pay X amount for that versus what we're delivering versus treatment as usual. There's a huge gap there. And the only way you can make up that gap is show that you are as good, if not better. It's sort of the challenge that Tesla's going to have now, whereby their cars, I believe, from what I've read anecdotally, I don't know this for a fact, but I believe their cars are smarter than us humans. But because it's digital, it has to be now infallible. And it's kind of a weird paradox that we live in as well. So, for example, a primary care physician, when they prescribe somebody to face-to-face therapy, between 30 and 50% of patients don't make that first appointment. That's the benchmark. That's the gold standard. We're delivering digital, and they're expecting 100% from us. There's just something not quite right. It's just disconnected. So what we try and do is make the data very, very, very transparent. Engagement, usage, access, patient satisfaction, pre-post, delta, t-test, all that kind of stuff. Because I think that's where the differentiation is, the outcomes, the showing the impact. I think that is going to be the ultimate final battleground of this industry.
Yeah. I know we only have 3 minutes, so I'm gonna merge one question that was asked with kind of a future gazing question. Looking back at, the years that have been COVID, what are some of the greatest learnings you've had that's informing, the future of the products in this space? But also, what do you think we need to see in 2 years, in 3 years to ensure that we're taking care of the mental health of our populations? Who wants to take that first? I feel like this is okay, Sarah, go.
I need to take part of it, and I would just say that clearly incentives matter, right? And we've always known that. But they're not 100% of the solution either, in the sense that you're never going to get 100% of anything, as Ken says. It's just impossible to do. So even in the time of a global pandemic, you're never going to convince everybody to get vaccinated. You're never going to convince people to do, there's never 100% of anything. And not necessarily that there's a right or wrong on that either. But I would also say, yeah, incentives drive action. And that hasn't changed. That's just an old adage from forever and ever, and it doesn't go away. And suddenly, you're in a COVID-19 situation, and things that weren't supposed to be telehealth or telemedicine, or things that weren't supposed to be digital, or things that should have taken 10 years to penetrate the healthcare market now took 12 months or 6 months or whatever they took. So for me, one of the biggest learnings coming out of COVID anyway, besides all the things that we still haven't learned, frankly, the effect, we talked about this in sort of a different session, right? But the effect on children and pediatrics, what's a COVID kid? There's a lot that's left to be unstudied, and the burden of that upcoming population into the mental health market is going to be interesting. But what has definitely not changed is that that incentives drive action, and COVID has proven that out. And I think to the betterment of the development of the digital offerings in the healthcare space.
Well said. We have 1 minute for one last perspective on that, on the future piece, Robert.
I think Sarah's right. I think the other component that, we build success one brick by one brick. And what Ken said earlier about feedback loop, I think is worth reiterating. And sort of like, in addition to incentives, we need to connect the dots for the consumer. And so that in a pretty real-time basis, they can understand in a measurable way that they're not only feeling better, but getting better, right? And one of the problems in healthcare in general is that consumers and patients, right? You go to your doctor and they tell you to lose 30 pounds, and you're like, seriously? Like, nobody can comply with that. But if you tell them to walk 5 minutes or walk around the block every day of the week, they can do something small and measurable. So I think we need to think about how consumer behavior is sort of, wired, and that work within those wirings, because I think changing is even with the incentives continues to be really challenging. So I think we continue to need to think about sort of more consumer engagement tactics that work in other markets as well. Healthcare does not have a track record of being best in class from this category. And so I'm looking to some other industry segments who do a lot of work around consumer marketing, and how do they think about motivating consumers to engage and become, long-term customers.
And on that note, I just want to say thank you to all of you. This has been really informative and a great conversation, and I can't believe it's been an hour already. So thank you so much.